The ARMA trial, which was conducted in 2000, investigated the role of lower tidal volumes in patients with acute lung injury and acute respiratory distress syndrome known as ARDS. Its findings continue to serve as the foundation for lung protective mechanical ventilation strategies in medical ICUs. Based on this trial, the ARDS network established guidelines promoting lung protective ventilations for patients with lung injury and ARDS. Based on these principles, our quality improvement study aimed to evaluate how effectively the medical ICU at Erlanger-Behrens updates and documents measured heights of intubated patients. Accurate height measurements is essential as it is used to calculate predicted body weight, which is a key factor in determining appropriate tidal volumes for lung protective ventilation. Our objective was to ensure that all ventilated patients had a recorded and updated height within the first 12 hours of MICU admission. To improve compliance within our study, we implemented an intervention that placed measuring tapes at all respiratory therapist workstations, making it easier for the respiratory therapist to measure heights during their initial assessments. We then assessed the impact of this intervention on documentation rates. This single-center retrospective observational study was conducted at Erlanger-Behrens Hospital in Chattanooga, Tennessee. Data was collected from the electronic health record system from a period of July 1, 2023 to February 31, 2025. Inclusion criteria included patients of 18 years of age who were admitted to the medical ICU and required mechanical ventilation for acute lung injury to the MICU and required mechanical ventilation for lung injury or ARDS. Pregnant patients and those extubated within 12 hours were excluded. Of the 187 patients reviewed, 87 were excluded based on these criteria. The remaining 100 patients were analyzed, 48 prior to intervention and 52 post-intervention. Statistical analysis for our quality improvement study showed that the calculated x-squared value using chi-squared test was 3.6928, slightly below the critical value of 3.841, and the p-value of 0.0546 was just above the standard significance level of 0.05. Therefore, we failed to reject the null hypothesis, indicating insufficient evidence to conclude a statistically significant association between the intervention and frequency. After discussing our findings with respiratory therapy, we discovered a critical flaw in data collection. Although the therapist reported that they were routinely measuring and entering updated heights into the ventilators, this information was not integrated into the electronic health record. As a result, our analysis may have significantly underestimated compliance due to incomplete documentation rather than an actual lack of action. The goal of this study was to demonstrate that a simple intervention, adding measuring tapes to the RT workstations, could improve adherence to lung protective ventilation guidelines. While anecdotal evidence from respiratory therapists suggested the intervention was effective, the lack of electronic health record integration masked these improvements. Moving forward, we plan to implement the new documentation protocols to capture measured heights accurately within the electronic health record. A repeat analysis will then be conducted to more reliably assess its true impact of our interventions.